I'll try to, just in 8 minutes or so, cover a few fundamental and basic concepts of what we are doing in a paper that is now in press, finally, with a journal. So you will hopefully be able to see the full paper within weeks when it gets published. So it's all about focusing on Fit4Labour, as a lot of you know, we've been calling it, that assessment around the onset of labor, that first initial practical CTG that a mother at term gestation may be undergoing when she arrives at hospital. Whether she's low risk or high risk, that's a bit of a different matter in this case, but if she's put on the CTG, and again, whether all women are put on CTG or not depends on the country. In our country, in the UK, we only monitor with CTG, so-called high-risk pregnancies. And then as labor progresses, whoever's getting oxytocin, epidural, or as risks arise, they can be put on the monitor. But really the questions, I think the previous talks were really useful because they talked about, and we all talked about, the complexities around this CTG, that it's not just as simple as we look at it, and it's not only that clinicians don't know how to read it and computers will solve the problem. In this forum, we've been doing this for a while, and we know that's not the case necessarily. There are physiological complexities. But for practical terms, thinking about the choreo talk, thinking about the Japanese database, it's very, very clear that how you arrive in labor, it's really important what happened to that fetus before, and that's why I'm very happy to have a lot of antenatally focused folk today here, even though we are in labor, we're spamming labor. Actually, I always allow in the program the antenatal ones as long as it can relate, because how that baby arrives before we first put it on the CTG ends up to be very important for us clinically to understand, or using computers or not, to understand how to monitor that baby or how to make decisions around that pregnancy. So I'm joined by Mariana, who will talk to you about the clinical parts more, and I'll just introduce to you some more of the data. I don't want to talk a lot about it, but I had this slide ready and wanted to mention we have the national health system here, as Austin was speaking earlier today in the UK. It's a huge problem the way the litigation system is set up, and that's enormously clear. We now pay more for litigation for maternity per year than the actual maternity care as a country. It is just unsustainable, and there's a lot of scrutiny in there's so many reports. We are probably the country with the best understood brain injuries in term babies possible. We've investigated nationally cases and studied what happens, what goes wrong. And Each Baby Counts program was a national initiative run for 5 years, persistently try to evaluate what happened for all term babies born with brain injury. And they ultimately conclude with investigation per case that about half of them are preventable for term babies in this country. And around 76% or majority of those relate to in our country, again, because we have midwifery care and we have a consultant-led care. It's quite different potentially than some other countries. Very often, so 76% of the half, the injury to the baby is potentially preventable with better escalation, better communication, better monitoring, just delays in care, delays of escalating, and so on. So that gives us some idea of how many are in principle preventable, going back to what we heard in the morning from Hiro as well. It's always been a challenge. So we have focused, as you know, in our team, we have a lot of data, but we focus on different things, but we felt that this is the low-hanging fruit, so to say, being able to assess correctly at the very onset of labor who is fit for labor in pragmatic terms. Obviously, that's a colloquial term. Obviously, we don't have a formal diagnostic, unfortunately, physiology-wise. But this could be anything like a choreo, like placental insufficiency, like growth restriction, all sorts of things that we don't fully always understand and how they mix up to end up with an injured baby at the end. So what we've designed is very, very simple. The paper that's come out, you see it's focused only on 20-minute CTG. available clinical risk factors that we all know in the clinic, like maternal temperature, gestation for the baby. Of course, we would like to have more information, and with time we have things like Dopplers or other measurements. But in a crude sense, all hospitals should have the data that goes into the Fit4Labour, and only around 20 minutes of CTG. Now, obviously, I'm an academic child of Chris Redman and the Dose-Redman system. For obvious reasons, 60 minutes is better than 20, but surprisingly, 20 minutes is already quite good. It gives you that crude estimate. And then for those babies who don't have a very reactive pattern, you can continue to 60 minutes and get more precise. But in simple ways, and we've worked a lot to have a simple risk score that shows the risk is part of the population. That's the best I believe we can do at the moment with computers and data. You know, how you do the metrics, how you do your models, obviously we can do a lot better, but how you communicate the risk really is like where you fall on a centile chart. And that should help clinicians triage and optimize their resources in the hospital, in particular countries like UK, where you need to know who to escalate for and who to escalate quickly for. And so that's the kind of the concept. And the picture I've given here is like how we want to integrate it in the electronic patient record system. Again, given that it takes on this information that it's already available, you don't expect it to need a lot of other inputs. At the moment, we haven't integrated it yet, but we have a number of partnerships and discussions of how and where it fits best. So the very important advantages of this kind of approach, which I know it's a little bit of a surprise maybe for this audience, and again, spending 20 years working on decelerations and monitoring the CTG throughout labor, it's still very important. All your work is still extremely important. It's just we felt that this is at least, you know, is the low-hanging fruit, where if we assess correctly at the onset with this very easy tool, then we can monitor more reliably afterwards, and I firmly believe that. And our tool has very much been NHS co-designed within the NHS, very heavily influenced by clinicians and by a lot of studies that Mariana is going to talk about. Importantly, it's really combining the CTG with clinical risk factors, and I think this is kind of the first time, or one of the first times, we can see how that can work. And that's very important. That's very important, really combining them in a way that clinician can combine them, and is trying to combine them, but after having 2 or 3 risk factors, the combinations between them are rare and the risks are not linearly increasing. Yeah, and it's just very difficult for clinical heads, especially junior midwives, especially in the middle of the night, to try to remember, even the information isn't at one place in the systems often, to remember that she's actually running a temperature, but she's also a 35-year-old nullipara with this CTG in front. That's potentially a bit different. And providing the risk into this kind of form where it's part of a population, it's actually really, really useful potentially, because can serve, I know we'll have a number of talks tomorrow about the needs of mothers. And we have designed this as a clinician-facing tool, but definitely there is a lot of potential where that information, when it's given in a structured, clear way, can underpin a discussion with the mother for her options based on her. And because we have so many unnecessary cesarean sections, that's also potential hope that it can just help you triage at the right time, at speed, in a structured communication way. So, and all of the risk factors that go in, then we've been playing with, some of you are familiar probably with the Shapley designs, we've been playing with the ways of how to explain the different contribution of each risk factor, whether it's CTG or clinical, towards the position of the score. This graph keeps evolving, we are still doing tweaks to it, but generally clinicians love it. But this is older design, we already have a better design. So the paper I want to mention is in press now, please watch out for it, I think it's a matter of a few weeks. The paper takes a lot of data, so I'll just conclude in 2 minutes and say that please check out the paper. I'm so pleased to see so many of our great collaborators, Malin and Austin, here today. You know, this was a colossal effort. Unfortunately, the first author couldn't join today, but we're looking at a total of 147,000 and more. And Fit4Labour was validated independently with the Karolinska data, with the Stockholm data, sorry, not only Karolinska, where low-risk pregnancies were is part of, because they do admission CTG to everyone. So in a way, we developed with older Oxford data, where compromise is more common. We validated with latest Oxford, fairly late Cambridge, and then completely independently, without us accessing without the data leaving the hospital. And I don't see Farad now, but thank you Farad as well. I don't see you. So colossal effort. So this is in the paper. I don't have time to go through it, but please talk to me later if you want. What that tells you is that if you look at the 4 risk groups, the way I had them on the centile, you can actually have a measurement for the risks of severe compromise. We only cared about these very, very poor outcomes, regardless of pH. Half of those in our database, they are not acidotic. We've known that for a long time. So we chose to not focus on pH, but we do follow what happens to them. So in the paper, you'll see data on the pH and so on. The important thing is that across the different sets, that triage is always consistent. Yeah, so if you split the cohort in 4 groups, they are 4 groups where it's guaranteed that the high risk is a high risk. And you can see, even though we trained, it's a prognostic model, so it's simple at this stage. Even though we trained on severe compromise, we also see that that links well to cesarean sections. So this is the latest Oxford data as a validation never seen by the model, and you can see this beautiful separation here. So you can actually really have more confidence that the risks are low in 25% of your monitored population, and in the top 5% escalate quickly. And you can see the more recent, and that C-section rate is emergency cesarean sections is rising. Very importantly, that assessment happens early at first hospital CTG or at induction as well. Inductions are in this data set. So in the main data set, that's 8.5 hours on average before the baby was born in practice. That gives you a window of opportunity to really get the right care at the right time and so on. So in the interest of time, again, this is all in the paper. You can learn more about this 1 in 3 across the different sets, very consistent result. And when you remember that 1 in 3 is actually not that low when you think you're onset of labor, and you're looking for this kind of up to half that are pre-labor vulnerable, or more than that. So just the last slide to say, as a culmination of 20 years of work, we finally actually spun out a company, a dedicated university spin out to bring this technology first in the UK. And you see some of my lovely business partners. Scott is going to join, I think, tomorrow. Jonathan and Rakesh are here. Mariana and Lawrence Impey will join later. But so I'm really excited to be now on this journey and kind of be working with partners a wider scale and see if we can bring a very small first step towards improving outcomes. And I'll pass on to Mariana. You have.
It's just a. Okay, so can you hear me okay? Yes, thank you. So what I'm going to tell you about now, after all the data and accuracy that Antoniya mentioned, is can we actually do something with this algorithm and transform it into something that our doctors in delivery suites can use it in day-to-day. So I'm going to tell you 3 things today. I'm going to tell you about the usability that I led together with our experimental psychologist that is in the audience, Xavi. I'm going to tell you about our first study, our feasibility study, and I'm going to give you a little bit of a teaser of a survey that we are running that a lot of you helped increase the numbers and participations that I got in that survey. So if you know anything about usability, and I know a lot of people in this audience knows what usability is a fantastic way of you knowing your user and knowing the interaction between the product, the website, whatever you are developing, and try to understand what they like, what they don't like. So you get a lot of feedback, and that's basically what we did with our first prototype of the Fit4Labour. So what we decided to do was to evaluate the usability of it, to test it in doctors and midwives. If you know anything about SUS questionnaire, that the sigla, which is System Usability Scale, is from 0 to 100. If you are above 68, it's the standard industry that says that your product is actually good and it can be commercialized. And between 68 to 80, it's good, in the good gap, and above 80 is excellent. So when we started, we weren't excellent, I must tell you that. But with a lot of work from the doctors and midwives together with the team, we developed a version in the Oxford hospitals. And that's the first square that you see. So we did a lot of sessions, and every time we met doctors and midwives, we gave them scenarios and we improved the tool. Until we got to a point that saturation, we thought it was achieved. And what we decided to do was, can actually a tool that works in the Oxford doctors and midwives, that they like, that they are pleased with it, can it actually be transferred, and can we go to Birmingham and Buckinghamshire? Birmingham is a big hospital, it's a tertiary hospital. where we went, and Buckinghamshire is a district hospital. And actually, we're quite surprised in a way that our tool, when we tested with doctors and midwives from other hospitals, people were quite happy with it. And you can see even some of them were even happier than the doctors in Oxford. So I think one of the conclusions here is if you invest in time in doing usability and create something for your users, that is us in maternity, me as a doctor and all my colleagues as midwives, it actually potentially can be transferred to other hospitals. So that was one of our learning points. We learn a lot from these usability sessions. I'm going to just tell you a little bit of things that we got from feedback. We had a lot of feedback. People had a lot to say, and they really enjoyed being involved in this. So we created 12 themes, but I'm not going to go through all of them. I'm just going to focus on some things that they thought. One of them was, and we all really like this one, one of the midwives said, is like a co-pilot. So we really like to be compared with aviation in obstetrics, because aviation is like our gold standard if you are compared with them. And what they said was, they like it to be supportive, but not a replacement. Doctors and midwives still want to keep their autonomy, but it's nice to have something to help them and to be reassured about their decisions. There was a lot of chats in these sessions, in our focus groups, on escalation. Midwives really struggle sometimes, particularly in triage. You have a lot of junior midwives in the UK, and they are the ones that make a lot of decisions, and they need to call the doctors. And sometimes quite difficult to bring the attention of someone to come to triage. And we also had some problems when you call the doctor, because at early onset of labour, the language that you use is not great. You just pick up the phone and say, I'm not very happy with the trace. It's very common for you to hear these words. But actually, that doesn't mean a lot when you are on the other side of the phone. So having the one language, having that risk score, that it puts you into the risks, having someone on the phone, she's in this risk group, that would be fantastic. So they really like that idea. And also at the safety net, they make a lot of decisions. We make thousands of decisions. This patient needs to go home. Can she go up? Can she go to the delivery suite? Where am I putting her? So it's that safety net. And one thing was very common in all the sessions was they all said you need to have mandatory training, and that was very important for us to start doing our training package, because you can have the best app in the world, but if your users don't know how to use it, they don't understand it, it's rubbish. So that was very important for us to pass on the concept idea of the Fit4Labour, as Antoniya said, that not every baby that starts labor is in the same position. So this is us doing some focus groups and usability sessions, and this is our latest version. As Antoniya said, we keep developing and we keep doing a lot of research around this. And our SUS score is slightly below the other one, but we are getting there. And every time we meet people, we talk to them, we improve, we always try to get better at it. But still, it's a very good score in terms that none of them scored it below 68, and we actually got some higher ones. So it is a matter of time that we will get there. So this is just a couple of photos of us recruiting, but the important question here is, can we actually use this in delivery suite? Can we actually use this in a patient that is in early labour contracting? And the answer is yes, we were able to do this. So we run the first prospective multi-site feasibility study in 2 hospitals. So we did it at Oxford and Buckinghamshire. And our primary outcome here was to see if we can actually get a risk report. And 94% of our patients were able to get a risk report. And the reason why not 100% was because this was the first time we were using the Fit4Labour, and we had some technical problems just with the IT part, not per se from the Fit4Labour. And we learned a lot from this. These hospitals were quite different in terms of IT structures, and we were still able to run the Fit4Labour. Another thing that is important here is to start seeing how your patients react to it. So I approached 106 women, and you bear in mind, these people are in pain, they are coming rushed through the delivery suite, and they are still being consented by me to have a research study. And of the 106, 90 of them said yes to me. So that was, I think it's a great number. So what did clinicians and women said? I have a small number of questionnaires because bear in mind the situation they are in labor, and 100% found it useful of our women, and 94% would use it again. And I have some sentence. You can see knowledge is power. It puts you in a good position to know what to do if you are armed with all relevant information. You can read others. Of course, not everything was as we expected. We got some surprises that some people didn't want to know their risk, and it was fine. So what we did, we just said, if you are happy to be recruited, we won't tell the risk to yourself or to your partner. We just keep it to the clinical team, and that was absolutely fine. They were still able to be recruited. From our clinicians, we had even less numbers from the questionnaires, but from the small sample that we got, people were actually very positive and keen to be involved and to know more. So this is just a little bit of a teaser. It's my last slide, I promise. So this is a survey that we are actually running. If any of the doctors, midwives in the audience want to participate, it would be lovely. We are now on 650 responses. So what we are trying to understand here, after all this effort from the team and trying to create something for doctors, this usability, co-development, all of these feasibility studies, what we wanted to grasp with this survey is how ready are our doctors and midwives around the world to have decision support tools like Fit4Labour on their daily practice. And so far we're getting very interesting results. I analyzed the data when we were around 400 and something, and Antoniya is going to present this in the FMF in Vienna this weekend, so just watch out for this information. But we were able to start getting an idea of what doctors and midwives are worried about, what would help in their trust. For example, another graphic here, they're worried about litigation, over-reliance, lack of being transparent. So you start to learn a lot from this, and I think this will help us move on with our project of the Fit4Labour. I just want the last slide is to say thank you for everyone that helped us, our women, our midwife, clinicians, our research, and our PPA teams that made this possible. And that's it.
All right, that was awesome, and I'm sorry that I was doing exactly what Antoniya asked me to do. Maybe just one single question, please.
Thank you. Thank you for this brilliant presentation, and it's wonderful to have a practical tool that is coming to in the labor room. As a clinician, I expect this for years. My main concern is how it was built. So it was built over 10, 15 years. And with all data. When I mean all data, it means whole management way to. So when you tag 1 out of 3 babies who have a bad prognostic, bad outcome, do you think this 30% that you can tag at the start of labor, it's already compromised babies, or it's vulnerable babies that will maybe be not well managed?
In the interest of time, I'm very happy to talk about it at length. That relates a lot to our first session. In reality, we don't know. It's a mix. I'm confident in some of them are already compromised. So you can see as well across the picture in their MRIs and there's other signs you can look at. But overall, it's a mix. That's the whole point. But practically, you need a tool to tell you where you are. But these questions are bigger, and they will keep coming as you. I know it's your first SPAM workshop, but you will see this time the program is more packed, so we are challenged. But this discussion is very, very important, and we will keep bringing it up as a team. You know, do they arrive compromised? What Hiro was talking a lot about. What happens later? Are they vulnerable? What does it mean if you do a cesarean section for those? Because you can't always prevent, you know, what does it, is that beneficial actually for that baby? So there's a mix, it's a mixed bag is my answer. It's more complex. It's not something you can answer briefly. But I'm fully aware.
Great. Again, thanks so much for the great talks. Very exciting to see this.